Hi everybody, Jessie here. We are going to do a Facebook and Instagram live about IBS constipation today. Let me get my partner in crime, Brooke, in here. Oh, I see Brooke is already here. Hi everybody, thank you for joining us. We'll be talking all about constipation today. Oh, we see a lot of people joining us on Instagram now. Okay, go live. Yeah, like what Brooke was saying earlier, we'll talk about IBS constipation, what are common causes of IBS constipation, what helps to find relief, and also identifying your constipation triggers. We'll also share a few patient stories with you to, give you more context on how to implement different things depending on, what your cause of IBS. Hear us and see us okay? Hi. Oh, we have so many people joining on Instagram. Thank you for joining us. And if you have any question, we got quite a bit of questions from Facebook, so we'll answer those as well. And if you're joining us live right now, and if you have any question, drop it in the comments. We will get to as many of them as possible. So yeah, thank you so much, everybody, for joining us. Okay, before we begin, want to just introduce ourselves real quick. I'm Jessie Wong. I am the founder of Team IBS Dietitian and IBS Freedom. And of course, I'm very proud also of one of our websites, which is pooppedia.org. It's a site where you can learn all about poop. I'm actively adding more actually contents to it, but you can learn more about different types of stool, what causes different types of stool. Like if you have diarrhea, what can cause it. If you have constipation, what can cause it, and what are ways to improve your stool consistency. So that's pooppedia.org. Actually, is it on here? It is on here. Yeah. Okay, and before we get into IBS constipation, I want to say, a quick word to thank our sponsors. So this educational session is sponsored by Ardilax, who supports patients' education and awareness, and they are huge on patients' advocacy to help patients get more access with IBS, which I'm really thankful somebody is taking the lead on doing that. And we just want to thank them again, for sponsoring this session. And this content that we're doing today, a disclaimer, is all education purpose only. It's not to replace your healthcare provider appointments. It's not for diagnosing IBS, and it's not healthcare recommendations. We are here just to talk about, what we know about IBS and give you tools that you can use and try. All right. Oh, and before we begin too, I want to let everybody know that we are doing a free giveaway for the month of November because this is Thanksgiving and we are really thankful for the community that we have. We are giving away access to 3 lucky winners to our IBS Freedom course. And it is a course that walks you through what we do with our clients step by step in video and workbook formats. Actually, all of our clients have access to it as well. The difference between our clients and just getting the course is they get our support as well because they tend to be more complex cases of IBS. But for simpler cases of IBS, this is some question we get a lot. It's like, do you work with patients who may just have a mild case of IBS? We do work with patients, but if you are a mild case, our course might just be sufficient. We walk you through different strategies for constipation, different strategies for diarrhea, and also I think the thing that people really look forward to in our course is the FODMAP diet, how to implement it properly and how to reintroduce and challenge food step by step as well. So we are giving it away. The giveaway ends this weekend, so make sure to join. If you are on Facebook, find our profile on Facebook. I just shared it in our IBS community for women. I should have shared it sooner, so sorry everybody on that side, but it is available. You can still join, and I'm thinking we can give away to 3 winners on Facebook and then maybe 3 winners on Instagram, depending on what platform you are. That way, we can help more people because we are really thankful for you. So Lots of opportunities, very high chance of winning, and it is a 6 month access. Usually with the low FODMAP diet, it does take time to implement. What we recommend is about 2 to 6 weeks on the low FODMAP phase, and then doing the food challenges, which can take about 10 to 12 weeks, depending on your symptoms, depending on how fast you are. It can be shorter for some patients, for some members too on the course. Their symptoms are so well managed after implementing the strategies we talk about, then they can challenge maybe 2 FODMAP groups every week. But it really varies person to person. Some of our clients, they do that as well. But most of the time, I would say giving it 1 week per FODMAP group and subgroup would be best. And in the course, we walk you through how to reintroduce and challenge the 11 different groups of FODMAP subgroups one by one, and the amount of food you need to eat. Okay, that is a lot before we even get to what we need to talk about today. Sorry, everybody. Okay, constipation. What is IBS constipation? Do you want to tackle that?
Sure. So IBS constipation is by definition fewer than 3 bowel movements a week, stools that are hard, dry, or lumpy, or stools that are difficult or painful to pass, and as well a feeling that not all stool has passed, incomplete evacuation.
Yes. I also have a question for people on Instagram. Could you hear me just now? Because I saw some issue with my mic. So I'm wondering if, I guess people can because there are still people
Yeah,
here. Okay.
yeah.
Yes. Okay. And so that is, usual general not recommendation, but definition of constipation.
hmm
However, when it comes to IBS, thank you for responding. When it comes to IBS constipation, the definition is more specific. And we usually use the Rome-4 criteria for diagnosing functional GI disorders. Do you want to talk about that too?
Sure. So you must have two or more of the following: a greater than 25% of your defecations involve straining, greater than 25% result in a lumpy or hard stool, greater than 25% sensation of incomplete evacuation, greater than 25% of the feeling of anorectal blockage or obstruction, greater than 25% of bowel movements you need to use manual techniques to have a bowel movement. And you rarely would have loose stools without the use of a laxative.
Right. And then, of course, a big one for IBS is it usually involves pain. And patients would need to
hmm
have pain at least once a week for a 3 month period, which is also why, it takes time to diagnose IBS because doctors need to rule out other conditions as well. Number two
hmm
is you have to have these symptoms consistently before getting a diagnosis of IBS. And the
hmm
biggest difference between like general definition of constipation and the IBS-C diagnosis or the criteria, Room 4 criteria is the 25%. So it has to be more than 25% of the time over a week period. Like, and these are very important because it gives us specific guidelines on how to diagnose and also numbers to work with when we are working with patients to see if we have improvement or not. So it's not just like I'm feeling better, but we are actually measuring using numbers.
hmm
Yeah. Okay. Um, Here is a question we get a lot. What are the tests people are usually recommended when they start having IBS constipation symptoms?
I think it depends on maybe your GI, but we really do want to rule out any kind of red flags, which a lot of times may be a colonoscopy, um, or why am I drawing a blank at what other tests they would do?
Celiac,
Um,
usually it's a celiac
oh,
disease
celiac,
test. Yeah.
yeah. Um,
We do see, I think I want to point that out too. We do see more diarrhea patients getting celiac tests, but celiac
mhm,
disease, about half of the patients actually get constipation.
mhm,
So if you've
mhm.
not been screened out of celiac disease, you really need to talk to your doctor to say, hey, can we get the celiac screening done? And celiac disease is another one of those conditions that is really difficult to diagnose. So start with screening first.
Mm-hmm.
Usually, by the time people get to us, they've done the celiac disease test, they've done some tests, either blood work or stool test for inflammatory bowel disease. And again,
Mm-hmm.
inflammatory bowel disease can go both ways. It can be constipation, it can be diarrhea, and oftentimes we see mixed bowel type as well. And then what else? And scopes, right? Colonoscopy. That's really important sometimes for constipation is to rule out abnormalities in your colon, because if there is physical blockage, then your stool is not going to come out. And if you have IBS symptoms that won't go away and won't resolve, that could be, you should escalate it with your doctor and say, hey, can we get further testing done? Oftentimes, if you don't meet the age requirements, like 45 and above, then your doctor is very reluctant to order a colonoscopy. I would say it's not your doctor's fault. It is really how our insurance system, how our healthcare system is set up, that insurance dictates what you get. But, document your symptoms, bring it into your doctor, communicate with your communicate with your doctor clearly what your symptoms are. We have a free symptom tracker. If you type in pain, don't do it now. It might just like kick you out of the live. But if you're on Instagram, you typed in pain, PAIN, or symptoms, I will send you DMs to ask you for your name and your email to send you a free symptom tracker that we use for all of our patients. And it is really important for you to document your symptoms and bring it into your doctor so you get the right test. Okay. And we talked a lot about all of these tests, right? And to get an IBS diagnosis, you will get a normal test result for all of these tests. Because if you have other GI condition, most likely it's not IBS. Can it overlap? Absolutely. But if you're new to the diagnosis, most likely it is the other condition causing you to have symptoms. But if you also fit the IBS criteria, we do see overlap in celiac disease and IBS, which is very common. We also do see inflammatory bowel disease overlapping with IBS. And I think we have some questions in our Facebook group about IBD, specifically microscopic colitis. And that is what we see a lot as well, that is overlaps with IBS. And sometimes in these groups, people do have a real food trigger, but oftentimes people can have constipation, people can have diarrhea, and sometimes it is mixed bowel type. And people with microscopic colitis or IBD or even celiac disease, they have a very sensitive gut. I would say their symptoms will be more severe and can take longer to resolve than somebody with just IBS. So, okay. Common causes of IBS, or let me talk about this. When we talk about constipation, we really think about one thing, right? It's just chronic idiopathic constipation, but there are actually 6 different types of constipation. IBS-C is one of them, but there is functional constipation, which is also chronic idiopathic constipation. I actually did a webinar, I did a presentation at one of the largest dietitian conference and really dive deep into functional constipation and how dietitians can help patients. So functional constipation, or CIC, is one, and then there's IBS constipation. The biggest difference between these two is IBS come with pain. Functional constipation does not come with pain, but straining, your incomplete evacuation, needing to manually remove stool, or not having, what was the other thing? Or having to strain and then having the sensation of in evacuation more than 25% of the time. That is the same between both. The biggest difference is the pain. And then there's also slow transit constipation. And then there is dysenergic defecation, which is a pelvic floor disorder, a pelvic floor dysfunction causing patients to not being able to have full evacuations or having very difficult time evacuating. There's medication-induced constipation. There are supplement-induced constipation as well. And then lastly is the constipation from inadequate energy intake. I saw a question here somewhere about talking about having food poisoning, bacterial infection in the stomach, and sometimes food poisoning or bacterial infection or sometimes viral infection can cause constipation as well. Usually we lumped it into post-infectious IBS. But here are, 6 to 7 different causes or different types of IBS constipation or different types of constipation. But when it comes to IBS constipation, it's a little bit more different. Do you want to go through the list of what can be causes to IBS constipation?
So a lot of the same, um, a lot of the same reasons as constipation, but
Yeah.
so it'd be a slow gut motility, the pelvic floor dysfunction, post-infectious IBS, medications. The one that is not typically thought of is the stress with the gut-brain axis, um, and then there's also uh, not enough fiber in your diet, the wrong type of fiber, and then with IBS too, it would be finding a food trigger, or even non-food triggers, which may be lifestyle or just life patterns kind of can be a trigger.
Mm-hmm.
So not a food trigger. It'd be um,
Right.
protected bathroom time, things like that, more
Okay.
lifestyle.
Let's talk about triggers in a little bit, but I think what we want to talk about too is what people usually think help with IBS constipation
Mm,
versus what actually helps, right?
mm.
Because somebody actually commented on my post today, on one of our posts about low FODMAP fiber. And the person said more fiber usually makes me more constipated. And that's what we hear a lot. So more fiber, I love what you talk about. Do you want to talk about that traffic jam thing?
Yes.
Yes.
So if you're constipated and you add more fiber, it's like adding cars to a traffic jam. It just makes it worse. So you've got to get rid of the car blockage, the traffic jam, or the poop jam before you can start adding it in. Um, or else it's just gonna it's a hot mess when you add more fiber to an already constipated
Right.
gut.
Right. And we can sometimes see this go both ways with the adding too much fiber. Actually, we have one of the clients that came to us. She was eating between 50 to 70 grams of fiber daily. Now, the recommendation is about 25 to 38 grams. We usually say just 25 to 35 to make it easier to remember. And when you eat too much fiber, it can really stress out your gut.
Mm-hmm.
And if your gut is not adapted to to get the fiber out of the way, it can cause a flare up, and that flare up could be a significant bloating, discomfort, and pain. And it can also be diarrhea as well in some cases. So, work on one of the things we really tell people to do is, if you are adding fiber, start very small. Even like 1 teaspoon, right? Or,
Mm-hmm.
1 teaspoon with a lot of fluids and slowly adding it,
Mm-hmm.
slowly increasing as you tolerate more fiber. And somebody is saying that happens to me. I know it happens to a lot of people, and we hear it a lot
Mm-hmm.
because I think in the US especially, we have this mindset of more is better. So if fiber is good for us, we're just gonna dump a bunch on our system and hope that it will be okay. But our
Mm-hmm.
gut really likes routine. It really likes, what do you call it? Regularity. Like,
Mm-hmm.
okay, if we are eating fiber, then, it's good. And well, consistently having fiber in the gut, then that is good. And if you are adding fiber, so for those of you who may not have thought of trialing fiber, so start with very low dose. You can start with 1 teaspoon. I feel comfortable recommending that to most people. Psyllium is what we
Mm-hmm.
usually recommend because psyllium is very well studied, is usually well tolerated by most people. And another thing we hear when people talk about psyllium is that I don't tolerate psyllium. And usually we find that when people add a ton of psyllium, and a ton could be 1 tablespoon or 2 tablespoons, right? It's a lot of fiber if you're not used to having these kind of fiber. We like psyllium because it is affordable, it is accessible, and it is water soluble, so it dissolves in water. It's gel forming, it's viscous, so it forms gel to soften your stool. And it is non-fermentable, especially for our IBS girly. Non-fermentable fiber is extremely helpful. Fermentable fiber can cause more gas, can cause more bloating, and it can just cause more pain when you have trapped gas. So for anybody, even in our clinic, this is what we recommend. We don't recommend any magic fiber, right? There are
That'd be great if there was magic fiber.
well, if a provider talks about a supplement that is magical, I would say run away from it. What you can get from a pharmacy, from a legitimate pharmacy, is going to give you more safety and security because pharmacies also want to protect their legal interests, right? They don't want people trying things that don't work for them and they get into legal troubles. So we usually recommend our patients to get things from pharmacy. I personally love Costco because it's just way more affordable and you can get them in bigger volumes at lower cost. But psyllium is a good one. Start small and then increase your dose every 2 to 3 days as you tolerate it. Don't jump to 2 tablespoons on day one. Start at 1 teaspoon, okay? 1 teaspoon at day one, and remember to drink a lot of fluids. Follow the instruction on the label. I think it's usually 1 dose with 6 ounces of water.
6 to 8 ounces,
6 to 8 ounces,
yeah, that's
right?
the other part. Adding fiber without adequate hydration is also a recipe for disaster too.
Yes, and we see a lot of influencers with recipes online where they just add fiber to a food, like to a muffin or to something, like without that added fluids. This can really cause more problem in your guts, especially if you are dehydrated to begin with. And, adequate hydration is one really big factor for somebody with constipation. And ideally, you get in more fluids earlier on in the day. Right? You don't wait until the end of the night before bed to drink, to chuck in your, 1 liter or 1.5 liter, depending on how much you need. I usually, well, both me and Brooke are really good on hydration. I usually keep a big jar next to me and I fill it up. I know I need to drink this like 4 jars a day. So I kind of mentally keep track of how many fluids I need. 4 jars, like this much water, 4 times, this is 2 liters. And then I also have coffee and then soup, so that adds a little bit more fluid. So know how much you need. What we usually recommend is probably if you're constipated, start at 2 liters and then increase if you need it, if you exercise more or if you sweat a little bit more, and then decrease if it's too much for you. And drink it throughout the day. Don't dump your system. Again, your system really likes consistency. Oh, consistency is the word I was looking for earlier. So, even with fiber, right, your gut is looking for consistency. It cannot handle a large amount at one time if there's already a traffic jam going on. Okay. So did we talk about that already? Common mistakes with magnesium probiotics and laxatives. We are big fans of laxatives. There are 2 laxatives that we recommend in our clinic routinely to every well, not everyone. It depends on how they respond. Number 1 is osmotic laxative. We recommend Miralax for patients with IBS constipation because it really helps unclog your system, right? Like we said earlier, if there is a huge traffic jam in place, what you really want to do is to resolve the traffic jam first. Now, a lot of people will tell us and say that my GI recommended me to try Miralax, but it did not work for me. What will you tell people when they've tried Miralax and it doesn't work?
They need to try again at a bigger dose.
And somebody said here too, Miralax is the most gentle. Absolutely. The reason why we love Miralax is because it's very gentle. It's an osmotic laxative, and what that means is that it draws fluid into your colon to soften the stool and help it come out faster. None of it is absorbed. Another osmotic laxative that we recommend is magnesium, but I have a profile highlight on my Instagram profile that teaches you how to select a magnesium that is third-party tested and what are the pros and cons of using magnesium, because magnesium does get absorbed. If you have a liver condition, kidney condition, or heart condition, we do not recommend it unless you've talk to your healthcare provider. So remember, supplements is not always better than medication. Medication is very regulated. Well, we are having some hiccups at the FDA, but in general, medications are still very regulated. They have to jump through more hoops to get approved. And once they are approved, they are usually very safe for us. And Miralax doesn't get absorbed at all. That means you don't have to worry about it affecting other parts of your body and other organs. But like what one of our listeners here say, more water. That is very true. When you are doing Miralax, you also want to ensure you have enough fluids going through your gut, because Miralax draws fluids to your colon. That means you do need more fluids to support other bodily function when you're taking an osmotic laxative. Magnesium can be a great one as well, but we do find people tend to respond better to Miralax. And you do have to take it consistently for it to work. And usually we say if you are taking a very low dose, give it at least 4 days, before you say it doesn't work for me. Because, if it's a very low dose, it's pulling in very little amount of fluids to your colon to soften the stool. So it will take longer for it to work. If you are somebody who are very constipated, which I think most IBS-C cases can say, I'm just so bloated, so constipated, nothing is working, then you might want to increase your dosage, right, of Miralax. Go up to 2 dose, go up to, say, 3 dose, but talk to your healthcare provider first before you do it. We dose our patients, but we look at their stool outputs every day, and we look at what their stool looks like. I'm going to show you. Like, we look at the real picture of our stools, our patients' stool, to teach them how to dose their laxative so that they can get to a type 4 stool with full evacuation. So, if 1 dose of Miralax or the dosage on the package is not working for you, talk to your healthcare provider. They should ideally give you guidance, but if they're not specialized in GI, they may not know how to give you guidance, but have them refer you to our gastroenterologist and then talk more about it, or work with a GI dietitian who knows these things. If you're wondering what full evacuation looks like, go to pooppedia.org. Go to pooppedia.org and look at the type 4 stool. We have real stool pictures on there to show you what a type 4 full evacuation looks like. And one of the big mistakes, I think, people look at their stool and be like, okay, I had a type 2 stool or type 3 stool, I'm fully evacuated. When in reality, they are probably not fully evacuated, but because they're so constipated, if they're going a little bit, they think they're fully evacuated. And that's something we hear a lot as well. And then we look at their stool picture. This is a conversation I actually comment on my patient's journal all the time is, I don't think you're fully evacuated. I think we need to up your laxative dosage and stay on a higher dose consistently and see what full evacuation actually looks like for you every single day. And that's how we learn, what full evacuation looks like for each of our clients so that we can recommend strategies accordingly. But if you don't know what full evacuation looks like or different types of stool looks like in real life, go check out Pooppedia. And earlier I talked about the symptom tracker. This is a symptom tracker that you can use to document your symptoms so that you better understand your body. So when you go to see your healthcare provider, you have the verbiage to communicate better. One example I want to give is when we work with constipation patients, they always tell us they have pain. But when we ask more about, so what type of pain is it? They may or may not be able to say, right? With constipation, dull pain is very common. Cramping is very common. Sharp pain is also very common. Sharp pain is usually related to trapped gas. Dull pain is usually related to a colon that is full of stool because you're carrying a lot of stool burden in your colon that can cause dull pain. So, being able to tell your provider what kind of pain you have, where the pain happens, how long does the pain last, how often does the pain happen, really helps us, the provider, understand what may be causing the pain and giving you the right tools to say, I think this is what's going on. Let's try this and see how it works. I hope that is helpful. That's a lot of information, but download our free tracker. It's completely free. We actually have a IBS patient's toolkit. The tracker is included in the toolkit. You can find it on ibsdietitian.com/resources. It was something intended for physician office, but then we found that people really wanted it. And we thought, why not just give it to everybody? So it looks something like this. It's an IBS patient's toolkit. It teaches you about symptoms, diagnosis, different types of IBS. What does a care team looks like for patients with IBS? This is really important because oftentimes you go to a PCP and then go to see a GI and then get a diagnosis of IBS, and then the doctors say, okay, go home and just manage it, deal with it yourself. It's not life-threatening. You will be fine. And people are not fine because it is very debilitating. I would say, even with IBS constipation, that's what I dealt with. And the pain, the dull pain that is constantly there when you can't go to the bathroom, and then the bloating, while it is not life-threatening, it's just debilitating because I feel like that pain just drains my energy away. And that was also when I had little kids at home and I really needed to take care of kids. And so my point is, you don't have to struggle, right? But oftentimes the care ants at the GI saying it's just IBS. But no, look at all the care team that can be helpful. GI, PCP, absolutely, you need them. The GI dietitian to help you identify food trigger, yes. GI psychologist to help you manage stress or help you create tools to enhance your gut-brain connection that can really help manage symptoms as well. Pelvic floor therapist, that's on here because in constipation, we do see a lot of patients may have pelvic floor dysfunction as well. Pelvic floor dysfunction can cause constipation. Constipation can cause pelvic floor dysfunction. So it's always good to include a pelvic floor therapist. And then what else? And then a little education on the low FODMAP diet. We have a grocery list for you. So you're looking at the list of things that you can eat, but it's not for everybody. And then this is the symptom tracker I was talking about. I really like our symptom tracker because it adds a bit of education on there so that you know what this is. So when you're documenting, you understand your body a lot better. And this is something what a lot of people tell us that, Jessie, I had no idea this is what my symptoms are. When I finally started documenting, people would say, I realize I actually don't have diarrhea. What I might have is constipation leading to diarrhea, which is, something very, very interesting and something we hear a lot of. If you don't know, what's causing your symptom, just by documenting your symptoms can give you a lot of insight. And make sure you tell your provider what your symptoms are in a clear manner, right? Because a one-on-one appointment with a GI is about an hour if it's a first appointment. Follow-ups are usually 15 minutes. It's really difficult to get the correct information through if you yourself don't really fully understand what's going on in your body. So start with documenting your symptoms. Where were we? Oh, probiotics. Oh, somebody said overflow diarrhea is very real. It is very real. And sometimes it may not be overflow diarrhea that people experience, but it could be something else that causes, constipation for a few days and then having diarrhea. And then sometimes what we're seeing too is constipation actually causing seepage and accidents. We'll get to the answers toward the Q&A toward the end. I'm seeing a lot of questions pop up on Instagram. But let's talk about over-the-counter management too. I think we talked about laxative, we talked about magnesium. Let's talk about probiotics. That's a big question we get a lot of. I don't want to recommend probiotics, but there are certain strains that can be helpful to manage IBS. But we don't usually recommend
Mhm.
probiotics for IBS constipation because we find that we don't have enough evidence to say that long term it is helpful. And sometimes what we see is patients taking constant a evidence-based probiotics for constipation, but in the long term, it actually leads them to have diarrhea. So a
Mhm.
different problem, right? And so we are reluctant to recommend probiotics without knowing, what other symptoms you have. But be very careful. We have a podcast episode that talks about probiotics that really dive deep into what types of probiotics are on the market, how to choose one for your right symptoms. Constipation is one symptom. We also want to look at pain, bloating, and other symptoms as well. And one of the things we hear about people taking probiotics is it can give them SIBO. So be very careful. That's actually something we see very often, and it could be diarrhea SIBO, and sometimes it could be constipation type of SIBO, which actually falls into a different diagnosis nowadays. It's called intestinal methanogen overgrowth. That's usually when we see. Oh, somebody said my primary recommended probiotics, but I ended up with SIBO. Yeah, which is why, probiotics is the biggest question, like one of the most common questions we get on any platform, even from our patients, but we just don't recommend probiotics unless we see a benefit. And there's only two brands that we use in our clinic, and we use it with our clients for a very short period of time because we know if they take it for longer, they can end up having diarrhea or having more SIBO. And we are very cautious, and we cannot make a big recommendation
Mhm.
on here without understanding what's going on in your body because you can end up having SIBO. So I'm so sorry for that. And when people do get SIBO, it is really frustrating because SIBO can be very difficult to treat. Recurrence rate is very high. And again, another reason why we don't put people on probiotics, and we are very, very strict on. But I can recommend two foods that are probiotics because they have evidence that they help with constipation. One is it Activia? Yeah, one is
Mhm.
Activia, the yogurt, and the other one
Mhm.
is Yakult, the drink. I don't have their picture here. We should probably do that. But these are probiotic foods that can help you better manage your constipation. And I think their risk of getting people to having SIBO is a lot lower than taking an over-the-counter supplement. So that would be something I can recommend just on here. But be very careful. Okay, next thing, medications. People are usually very afraid of medications. What should we say to people?
Oh, I don't know. There are some useful medications. I think they can be very helpful for some people. I think we end up seeing the people that they're not helpful for. But
True.
Linzess, Trulance, Motegrity, Ibsrela, are some of the commonly prescribed ones that can be really helpful.
Yeah, absolutely. And with IBS, right, everybody is different, and strategies to managing their IBS can be very different. So, for example, a lot of the times we see patients taking Linzess, they would have diarrhea. But then there are cases where it works very well for the patient. So it can be one more tool. I think
Hmm.
don't be afraid of prescription. Try it. If one doesn't work, try a different one. I mean, after you've exhausted the
Hmm.
over the counter options because everyone is different. That is something to think about. And medications are, again, very well studied. We know their side effects, but do document it and let your doctors know if you do notice any side effects. I think one of the big problems people see with prescription medication is their cost. And this comes down to access, right? And how much insurance is willing to cover. And one thing I love about Ardilex is that they are actively bringing patients together to share their story with legislators so that we hope that people can get more access to see GIs, or maybe, having dietitian appointments be included if you have IBS. Right now, Medicaid and Medicare does not cover GI
Mm-mm.
nutrition.
Mm-mm.
And it makes accessing a dietitian, such a big hurdle, and which is why we have the course, right? The self-paced course. So even if you don't have a dietitian that work with you one-on-one, you can do our course at a very low rate, and you have access to us to ask us questions in the course. But medication, I think that big hurdle is the cost. And what we hope to do as, IBS advocate is to really let the legislators know that, hey, patients with IBS have, when patients have IBS, it significantly impacts their quality of life. There are different strategies that can help with IBS. Medication can be one of them, but the big hurdle is the cost. And if insurance can take up more of the cost, it can be more available for patients who need it. And we know we are looking at potentially people being dropped out of insurance next year. And how can we still help patients get the medications they need, right? Because some of these medications could be hundreds of dollars a month. I think hundreds of dollars is what we tend to see with the IBS medication. It is a big cost if insurance is not covering a big chunk of it for you. So, I think that's where the big hurdle is. But if you are somebody with good insurance, don't be afraid to ask your doctor for IBS-C constipations. There are so many on the market. If one doesn't work, try a different one. Another one that we had the patients do, and with really good success, was the Vibrant, right? It's the capsule
Mm.
where it's a pill that vibrates in your colon to help things
Mm-hmm.
come out faster. And I thought that was just, wow, amazing, mind-blowing, super innovative. And it's not for everybody, but it works very well for some patients. Okay. I think we talked a lot about what people think of IBS, how to help with IBS and what actually helps with IBS, right? So fiber, over-the-counter laxative, prescription medications, beware of probiotics because it can give you SIBO. And when people have SIBO, it can be a lot more difficult to treat. It could be the diarrhea kind. It can be the constipation kind. It could be just a lot of burping and smelling gas. The IBS Nutrition Podcast has an episode all about SIBO. Take a listen. It's when you have SIBO, you can still manage it. Don't worry. Okay, let's talk about constipation triggers. Do you want to maybe touch on some of the triggers that we see quite
Yeah.
commonly?
So food triggers would be some high FODMAP foods. Um, Dairy could be a big one, and dairy or lactose, and artificial sweeteners. Non-food triggers could be sleep or lack of sleep, stress, hormone fluctuations, um, and I'm trying to think of any other um, in
Protected potty time.
protected, not, yes, protected potty time. So not allowing your self to have enough time to have a bowel movement in the morning. So that's really important. And one just kind of flew across my brain and left. I can't remember what I was going to say.
Meal timing. Oh,
Oh,
yeah.
yes. Consistent meal timing, as well as what we talked about earlier, trying to balance your fiber and not having like a 30 gram of fiber breakfast and then very low fiber lunch and dinner. So consistent fiber balancing.
Yeah. Somebody asked about what about exercise? Exercise is really, really helpful. It,
Mm-hmm.
especially, I think we talked about sleep, stress, and then also exercise. These are things that can help improve our gut-brain connection, right? But then when
Mm-hmm.
it comes to exercise, um, the comments also said lifting weights equals to diarrhea meat lift. Okay, we want to choose
Oh.
the exercise that actually works for you if you are having
Mm-hmm.
issues, right? I think maybe it's time to see a pelvic floor therapist as well to just get
Mm-hmm.
an assessment to see what is going on. This is, I think, more common than we think is that constipation can cause accidents. And a lot of
Mm-hmm.
the times it's not like full-blown diarrhea, but overflow diarrhea coming around and causing
Mm-hmm.
seepage and causing accidents, and people get
Mm-hmm.
really frustrated. There
Mm-hmm.
are a lot of reasons why that happens, but definitely consult with a pelvic floor therapist because, make sure your pelvic floor is healthy. And sometimes lifting weights, if you don't do it properly, it can hurt your pelvic floor as well. So beware.
Mm-hmm.
And what did we talk about? Let's elaborate a little bit about meal timing and protected party time. Do you want to do that? I think you have such a good spiel on that.
Sure. So protected, I have one client in particular in mind, and she works a lot. She travels a lot. She has to already get up early to go to work, and I encouraged her to get up a little bit earlier, even 10 minutes. Have a warm beverage, eat coffee. If coffee is that helpful for you, coffee or any warm beverage can kind of trigger things. Maybe even a small snack to get your gastrocolic reflex going if it's quite early. And then doing some stretching, some kind of exercise, yoga, something like that to also
Mm-hmm.
help get things moving. And then leaving yourself time to have that bowel movement before you go to work can make a world of difference. But kind of finding the bathroom routine that works best for you and not just waking up, getting dressed, running out of the house without letting yourself have time to go to the bathroom, especially if you are kind of phobic of going to the bathroom in a public place. It would be even more beneficial to give yourself time at home to do that.
Right. Right.
Yeah.
Creating a routine that works for your body
Mhm.
and really
Mhm.
giving yourself time because when we're constantly on the go, 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 our brain knows it and it will say, hey, this is not a good time to go to the bathroom. So let's hold it. And for those
Mhm.
of us with IBS-C, myself included, once I hold it, I may not have that urge at all the
Mhm.
whole day.
Mhm.
But you can also have other tools to manage it. But um, create a routine that works for you. Brooke talked about gastrocolic reflex just now. Gastrocolic reflex is a normal reflex that when you eat food, there's food in the stomach. It sends a signal to the colon to say, hey, it's time to go to the bathroom because food is coming. It is
Mhm.
really helpful in going to the bathroom. One of the usual recommendations from doctors, GI doctors, is after a meal, sit on the potty for 10 minutes. Now, we are not going to tell you to sit on the potty because that is an old advice, but there is some truth to the advice. But after a meal, the 10 minutes after that, don't rush. Give
Yeah.
yourself time to maybe do some stretching, walk around a little bit, maybe even jumping up and down a few times because the up and down motion, right, also helps things kind of move along in your gut as well. Like that helps allow your bowels to say, okay, I can go to the bathroom now. But if you're rushing, that urge might just be like, bye, out the door. Oh, the
Yeah.
other day, I want to share this really funny story. The other day, my daughter had a very early soccer game. And when I have those kind of days, my routine is messed up. I don't go to the bathroom. But on the way there, it's so funny. They wanted to listen to classical music. And I listen to classical music and I'm like, oh, I'm more relaxed. I feel good. And then the urge actually came back. I was like, that gut brain connection
Yeah.
is
Yeah.
really so important. So
Yeah.
find what works for you. What we also like to recommend is patients doing bowel massage.
Mhm.
After a meal, do some deep diaphragmatic breathing, do some bowel massage, to help things move along and really relax your muscles in your abdomen, relax your GI tract. And then, yeah, what ended up happening was in Washington, I think we're very lucky. There are a lot of community centers that are government run. I actually found, and they have really nice bathrooms. And I say nice as in they have like toilet seats, it's nice stalls, they have automatic flushing, so it's always clean. And so I was able to find a community center and go to the bathroom. But I am one of those people, if the bathroom is not clean, like with soccer, I think it's always the
Ugh.
porta potties or
Yeah.
like those
Porta potties.
portable.
Yeah.
Yeah, I
Yeah.
can't do that. It's just too gross.
Yeah.
I wouldn't
Yeah.
even want to go in there. But we're very lucky. We have a lot of community centers. I just need to look for one nearby and then use their bathroom.
Yeah.
But
That's
classical
another,
music, yeah.
yeah, that's another thing. I think if you constantly avoid when you feel that urge or you're too busy, when you feel the urge, act on the urge. Because if you train your body to kind of ignore that, then you kind of lose that sensitivity you lose the urge to go. And then, so you've got to like honor that urge, which you
Yeah.
did.
Right, right. Because if I don't, then it will be the next
Mm-hmm.
day. And then
Mm-hmm.
sometimes, right, with IBS-C, the iffy part is the next day may not happen as well. That's
Right.
with travel. I think travel is really hard.
Mm-hmm. Mm-hmm.
Nowadays, I'm smart. I bring Miralax with me when I travel. If
Mm-hmm.
I can't go, I am downing that Miralax, and it really
Mm-hmm.
helps me.
Mm-hmm.
And we talked about this earlier. For those who are joining now, you can go watch the replay when we posted. We talked about Miralax, why it works, dosing of it. Um, and okay, because we're talking about, how lifestyle can really help. Somebody reminds me of one of our past patients. Actually, her name is Kendra. She is we want to share with you some client stories to give you, some inspiration of what works, right? And give you inspirations to know that you don't have to struggle with IBS constipation. Yes, it is, a diagnosis, it's debilitating, but there are ways to manage, like we talked about earlier, and putting it in practice. One of my past clients, her name is Kendra. She is the loveliest person. She's a healthcare provider. And what does that mean? That means she works a lot. She has to go into work very early. She came to us extremely bloated, and she had so much pain in her abdominal area because she was very constipated. She was afraid to eat. I remember jumping on a quick call with her just to see if it's a good fit working together, right? She's so afraid of eating. We went into her pantry with her to see what she had in her pantry and in her fridge to come up with something that she can eat while we worked on resolving the constipation. And and once we got her to be able to go every single day, what really helped her was what we talked about earlier, creating a morning routine. Drinking a cup of coffee in the morning to after eating breakfast or during eating breakfast, right? To help her have that urge and saving time for her to go to the bathroom. And another thing that really helped her was bowel massage, massaging her bowels to relax her body because again she works in healthcare, she's always very tense, and with her IBS constipation, she actually told me this, I'm sure everybody can relate, is that the constant pain and discomfort made her very unpleasant to work with, and she noticed that about herself when her IBS flares up. She's just not a nice person, and she hated it about, having IBS because of that. And I think that's something we don't talk about enough, and we probably should talk more about it, because when you're uncomfortable, it's hard to be smiling at people, right? It's hard to be
Mm-hmm.
pleasant. And that's something she felt ashamed of. But if that is you, don't feel ashamed of it. An invisible illness is very, very challenging because people don't see you having a disability, but IBS is really like, unmanaged IBS is really like having a disability because you
Mm-hmm.
have pain a lot of the times, and pain and discomfort can be very disruptive in life. But anyways, let's go back to her story. She had significant constipation. She was on over-the-counter laxative and it wasn't working for her. We actually switched her over-the-counter laxative to find one and find the right dosage that worked better for her. And she had consistent full evacuation every single day. And when she had full evacuation every single day, that's when we did the FODMAP challenge. And here's the thing. She came to us really afraid of food. She wouldn't eat anything. Like, we had to pick out things from her pantry for her to eat. But once we worked on resolving her constipation, she was able to do all the FODMAP challenges with no food triggers. She didn't have any food triggers. So if that is you, right, remember, not everybody with IBS have a food trigger. If you're very constipated, if you're not going to the bathroom daily, then when you eat FODMAPs, it's going to go into your GI tract, it's going to stay there, it's going to ferment, it's going to cause pain, it's going to cause discomfort. It may cause a lot of gas as well, but it's not necessarily the FODMAPs causing it. Mm-hmm. Right? You need to work on your gut motility first. And in her case, what really helped her is creating a routine in the morning to help her go to the bathroom. And if she needs, more support, she can use the over-the-counter laxative that actually works for her. Getting enough sleep was a big one for her because, again, she's a healthcare provider. It's hard sometimes for healthcare providers to get enough sleep, but, she said, IBS, taking care of my IBS is a priority for me. So I'm going to take care of my body and I'm going to feel better. Hydration is super important for her. She wasn't drinking enough fluids to begin with. So we really worked on that to make sure she was hitting her fluid goal every day. And fiber. I think in the US, the statistic is over 90% of patients or over 90% of the population are not getting enough fiber. And of course, she was one of them. So we really worked on increasing her dietary fiber slowly to help her meet her goal of about 30 grams of fiber per day. And she noted that toward the end of working together. On days when I'm getting enough fiber in my diet, I have perfect poop the next day. I'm good. I don't have a lot of IBS symptoms. It's a lot more manageable. And she could tolerate, and like I said earlier, when we did the FODMAP challenge, she was able to tolerate all of the FODMAP foods without any issue. Now, here's the key, right? Full evacuation every day. And with IBS constipation, that is really important because that full evacuation every day also allows your colon to slowly shrink back to its normal size. Because for those of us with constipation, we tend to get thicker poops when we are more constipated because they're more compacted, they're more dry, they are more stuck in the colon. So, having a full evacuation every day really allows your gut to go back, to shrink back to the normal size, to have better sensitivity and also better evacuation. So I wanted to share with you that story because a lot of people come to us with IBS constipation being really afraid of food and they don't necessarily have a food trigger. Now, on the other end of the spectrum, right, we do see people who have food triggers. This is actually another healthcare provider. When we were thinking about constipation cases, we were like, okay, these two are really good cases to share because some people do have food triggers, but most people don't have food triggers. Mm-hmm. Do you want to maybe tell us a little bit about Margaret's case?
Yes. She was actually she came to us on a prescription medication for constipation, but she was still constipated. Mm-hmm. She did a lot of lifestyle modifications. She changed her exercise, but she also, we did an elimination diet and she started feeling much, much better. And we did figure out that she did have a food trigger. And when we cut that out, she was able to tolerate, was it all the FODMAPs or most of the FODMAPs?
I think most of it. And then some of it were at the lower dose, but she could tolerate all of the FODMAPs. But I want to also go back to this story too. She is a healthcare provider herself, and she's seen, I think, at least 2 to 3 GIs.
Yeah.
And then they tried different things. And one of the GI told her to do the low FODMAP diet by herself. And she did. And she said she didn't recognize any triggers. But she also said, because she did it wrong. The low FODMAP diet is very complicated. I really hate it when doctors give patients a one-page handout and say, go try the low FODMAP diet and see if it works for you. And at that time, before she came to work with us, she did the low FODMAP diet and she felt like the diet was successful because she went from not going to the bathroom at all to having a small amount of bowel movements daily. And these are like these type of bowel movements. And for somebody who is very constipated, she thought that was working. No, it's
Mm-hmm.
not working, because you really need to have that full evacuation every day and not just tiny little bits comes out, especially for those of you who may be eating a higher amount of fiber to try to go to the bathroom. Make sure your output is, make sure what is coming out is actually what you're eating after going through the digestive tract.
Mm-hmm.
And she's tried, I think, prescription medication. She's tried over-the-counter laxative. Nothing
Mm-hmm.
was really working. And in cases like this, we did redo the low FODMAP diet with her, right? Because the first time when she did it herself, she wasn't doing it properly. She was cutting out too much food. She was not, and then there were certain things that she thought was low FODMAP, but was not low FODMAP. And she wasn't doing other things to support gut motility, like we talked about earlier. Those are non-food triggers that can really help you go to the bathroom. And after working through it, she did have a different food trigger, which is not FODMAPs, but when she eats her trigger, it just slows down her gut completely. And she ended up being very constipated, feeling very distended and very bloated.
Mm-hmm.
She was actually somebody who came to us because she was significantly bloated. And when we were working together, she said she finally knows what full evacuations feel
Mm-hmm.
like. And that's how long she's been with constipation. And she finally knows what full evacuation feels like. And she was able to was she wearing jeans for the first time
Mm-hmm.
and
Mm-hmm.
not feel uncomfortable? Because
Mm-hmm.
for those of us with IBS-C, myself included, I just cannot wear anything very tight. There's always discomfort. She was somebody that was really lovely to work with, because she documented everything in her journal, and it was easy for us to see when she has full evacuations, when she didn't have full evacuations, when would we adjust her laxative to help her improve the output or the volume of her stool, that output of her stool. And
Mm-hmm.
also she uploaded pictures of her abdominal area, because she came to us extremely bloated. And it's the
Mm-hmm.
kind of distension that was that's very, it's very
Pronounced.
uncomfortable. Yeah, very
Yeah. Yeah.
massive. Yeah,
Yeah, yeah. She
yeah.
also was a person that had done high intensity exercise, and she did notice during the program that that made her bloating worse. So she
Mm.
changed her exercise to be more Pilates and walking, and that really helped with her bloating. Now, I'm not sure now she could be back to more high intensity that she's, resolved the issue, but she did. That was really helpful too. It's not just about, um, you know, it can be about modifying your exercise so that you feel better and feel
Mm-hmm.
the exercise makes you feel better, not worse, which is helpful.
Right, right.
Yeah,
And finding the right
yeah,
exercise. And with
yeah.
constipation too, sometimes, if it's too intense, the exercise is too intense, it draws fluids away from our intestines.
Mm-hmm.
And if you are full of stool, that can be very
Mm-hmm.
uncomfortable. That can actually cause inflammation in the
Mm-hmm.
gut. Okay, let's do some Q&A. I think we talked a lot. Oh, but before we jump into Q&A, guys, if you have questions, put it in the chats here, and we're going to go through the questions we have on our post and our Facebook and Instagram posts as well. Um, before you before we jump into Q&A, we are giving away our IBS course. It's our IBS Freedom course, where we walk you through step by step how to, improve gut motility. Actually, the course includes everything we talked about, the lifestyle challenges, non-food triggers to help you work through it to improve your gut motility. And of course, everybody wants the FODMAP part. We do have the FODMAP part as well, how to implement a low FODMAP diet properly, and then how to reintroduce or challenge FODMAP foods properly, because it's not adding a food to your diet and see if you have a reaction. It's actually a 3-day challenge, and with very specific amount of food to eat. And
Mm-hmm.
depending on the food and their FODMAP contents, there are different amounts as well. So the course walks you through all of it. And toward the end, it helps you create a long-term plan that actually works for you. And what we mean by long-term plan, we mean, number one, preventing symptoms from coming back when you know your triggers. Because if you know your triggers, you know how to avoid it properly. And number two, if symptoms do come back, it doesn't become a massive symptom because you have the tools to manage it very quickly. So, you know, the intensity of your flare would be a lot lower because you know how to reverse the flare very quickly. And number three, I think one that everybody looks forward to is having a plan for travel, for special holidays. It's all included in the course. It's very, I have to say, we are very proud of our course because it's a lot of details. But it's not overwhelming because all of our videos are very short and they're very step by step. If you have IBS-C, start with this video and then watch this video and then watch this video. We try to keep it very short so that it's doable and it's easy to implement for anyone. Okay, we have a question here. Can I take magnesium citrate capsule every day? You want to answer that?
Sure. Yeah, so I think magnesium citrate, as if it's third party tested, it's safe. It would be fine to take it every day. The caveat being if you're getting up to like 1,000 milligrams of magnesium, it's to get, to have a bowel movement, it's probably better to do Miralax because that's just a lot of magnesium. It's probably not as effective as you would want it to be.
Yeah, and I wanted to add to that as well, and talked about this earlier. I have a profile highlights on supplements. Magnesium is included in there. Magnesium can be a really good long-term tool if you don't want to take Miralax, but if, like what Brooke is saying, starts at 250 milligram, talk to your provider if you need to go up, or look at the dose on the bottle. Don't go anything over that, and make sure it is third-party tested. And if you're taking a high amount of magnesium, then, be careful because magnesium is not without side effects. It has its own side effects, and we don't want to say yes without knowing your medical history, medical background. Like we said earlier, if you have a kidney condition, liver condition, or heart condition, you should not be taking magnesium without talking to your provider. So do we recommend it in our clinic? We absolutely do recommend it, but only when a patient has regular full evacuations every day, because we know magnesium doesn't work as well as Miralax. In most cases, not everybody. Everybody is a little bit different. Okay. Somebody said, this is an interesting question. Somebody said, this is a Facebook question. I started on a statin and got microscopic colitis. We've never heard this, but we do want to say, and somebody asked, how was that diagnosed? I had a colonoscopy and they found polyps where they removed, but nothing else. I kind of want to talk a little bit about microscopic colitis as well, because that's something we work with. And to diagnose microscopic colitis, usually you would do a colonoscopy, and they would take samples from your colonoscopy to biopsy some samples to see if there's inflammation inside. Usually with microscopic colitis, your colon will look great during the colonoscopy, but when they put it under the microscope, they can see inflammation in certain parts. So experienced GI would know where to take the samples, send it to the lab, and then they will give you the reports. And microscopic colitis can cause diarrhea, can cause constipation as well. And sometimes in our clinic, what we see is people do have food triggers related to microscopic colitis. And we had a client came onto the IBS Nutrition podcast to share her IBS journey. Her name is Lauren. She actually has microscopic colitis, and her journey is a little bit different than other IBS patients' journey. So if you want to hear more about that, go listen to the IBS Nutrition podcast, the episode with Lauren. Yeah. Okay. Here's a question about FODMAP. Can the same FODMAP have different tolerance level? Like some fructans, okay, but not all? Absolutely. Actually, yes. We test fructans 4 different ways in our program. We do it, garlic is one, onion is one, wheat is another one, and then fruits and vegetables are other ones. So fructan, because it is very potent, it affects a lot of people. It is one that we do test it out differently with different foods. And the reason why we do that is we find that people tolerate fructans okay, for the most part, in fruits and vegetables and even garlic and onion. But sometimes if it's with wheat, people may not tolerate it. But if In those cases, we do suspect other conditions such as non-celiac wheat sensitivity, and we do a challenge with just wheat without the FODMAPs as well. So, like in our last IG live, or Instagram live, we talked about 9 different food triggers for IBS. So these are things that we are constantly thinking in the back of our head. Is it just FODMAPs? Is it something else? And there are actually 8 other foods that we look for, food groups that we look at when we're working with people. Yeah, somebody said, yes, I can tolerate weeds, but not broccoli. Yeah, broccoli is a cruciferous family, so they do cause more gas. What we tend to find again is when people have full evacuations, then they can tolerate even the cruciferous family a lot better. But it's person to person, do your challenge, 3-day challenge. And Brooke, do we test for a FODMAP with cruciferous? I think we do let's look at our challenge schedule. I think we do
Not,
cauliflower, right? But it's not for the
no, I think
cruciferous.
it's
They
mannitol,
changed it.
cauliflower. They changed their whole thing.
Yeah.
It used to be, I believe, mannitol was cauliflower, but they've changed it to not be cauliflower, and I can't remember why.
Yeah.
Something else. I want to say cauliflower had 2 FODMAPs in it, but I don't
Mm-hmm.
remember which one.
Yes, and the live is available on our feed. It's from about a month ago. You can go back to find it. It was a really good live. We had some technical difficulties, so the live splits into 2 videos. So watch part 1 first, and then watch part 2. Okay. Okay, so we had another question. Somebody talked about parasites. So this question is, I have a question about so many online videos about parasites and plastic in our guts. Is it true? If so, how to cleanse safely and effectively?
If you live in the United States and haven't traveled abroad, and you're not playing in the dirt, it's very unlikely that you have a parasite. If you have traveled in a third world country, yes, you could potentially have a parasite. I have seen doctors, because it's a stool test, will test for parasites pretty quickly if you've had diarrhea, you've traveled outside the country. Um, Cleanses, I have never once, nor will I ever recommend a cleanse. They're more
Mm-hmm.
dangerous than people think. So no cleanses. You can get tested for parasites. Um, the plastics, not sure I've seen any research on that.
Yeah, I
Uh,
think the plastic is newer, but you know one
yeah.
thing about plastic that I read recently is that fiber helps you take it out.
Oh.
But of course, you need to be pooping, right? So, I mean,
Mm-hmm.
microplastic is everywhere.
Mm-hmm.
But I want to second what Brooke was saying. If you live in the US, parasites is very unlikely. If you hear
Mm-hmm.
people talk about parasites, run, especially provider that say, oh, your gut symptoms is all from parasite or
Yeah.
some form of overgrowth. Be careful. It's not evidence-based.
Yeah.
And your doctors can test for it. Don't
Mm-hmm.
go to somebody who is not a real doctor to get these
Mm-hmm.
tests because there
Mm-hmm.
is a whole business that sells you fake test, fake
Mm-hmm.
diagnosis, and supplements to fix your fake diagnosis. So be
Mm-hmm.
very careful of that. And when I saw that question, that was what came to mind first. But I think, and I think they had a follow-up question about eating sushi as well. So if you are living in the US, if you are going to restaurants that are safe, that have like what is it, food safety grade, that is, then I don't think you need to worry so much because we do have really good food safety regulations. I'm
Mm-hmm.
saying it a little bit slower because I do think a lot of them got laid off earlier this year.
No.
So So that's, we
Yes.
are expecting more people to get food poisons, which is unfortunate
Yeah.
because it can
Yes.
cause post-infectious IBS. But I do still
Yes.
think parasites is not a big concern as far as what we are
Yeah.
seeing in the United States or Canada or, in well-developed countries, especially, I
Hmm.
mean, in other well-developed countries outside of the US, you don't have to be concerned. But if you are
Right.
concerned, you can talk to your doctor about this,
Hmm.
PCP or GI, because they can test for it. Most of
Hmm.
the time with parasites, people do tend to get diarrhea.
Hmm.
That's a more common one. But with microplastic, it is more common. I think there was one study that came out and said our brain has like a tablespoon or something of
Oh, yeah.
microplastic in it.
Yeah.
And I'm pretty sure it would be in our gut as well. But if you are
Yeah.
pooping every day, right, you are potentially also pooping out the plastic.
Right.
And one of
Right.
the studies, one of the reports that I looked at recently, I can't remember who, I'm so sorry, I can't reference, but I think what they said is fiber helps to remove those
Hmm.
plastic
Hmm.
in your gut as well,
Hmm.
especially because we can't avoid microplastic.
Right.
And
Yeah.
with the EPA deregulating, we are potentially seeing more plastic and more harmful substances in our food. I'm sorry,
Hmm.
I'm going political, but I do think it affects our health, and this is a public health issue that we all need to be aware of. Um, yes, so eating enough fiber. And when we talk about eating enough fiber, right? We talked about it earlier, and we talked about fiber supplement earlier. And another thing is, if you're on the low FODMAP diet, know that you don't have to be on the low FODMAP diet, and you should not be on the low FODMAP diet for longer than 6 weeks, not
Hmm.
under a registered dietitian.
Hmm.
Sometimes our patients do go slightly longer depending on their life circumstances, depending on the severity of your symptoms. But if you are trying the low FODMAP diet by yourself, don't go longer than 8 weeks or 6 weeks. Oops, my headphone is dying. So hopefully this will
Yeah.
still work. But let's finish up to see if there's any other question. Can you still hear me okay?
I can.
Yeah. As somebody said, is there a less constipating option for gluten-free other than psyllium or sorghum? Um, is this fiber? We do also like PHGG as one of the fiber
Hmm.
that we use, but it is fermentable, so it's not for everybody with IBS. Let's just put it that
Hmm.
way. Psyllium is usually the safer option, but again, start
Hmm.
very small and then increase slowly.
Now I can't hear you.
Okay. Can you hear me now?
Yes.
Okay. I think my headphone has completely died, but it's okay. Okay. All right. So let's see. Somebody also talked about gentle detox that they bought on Amazon. I'm like, do not buy any detoxes because they are not regulated, right? In the US,
Hmm.
especially. Senna can be something good to try. It's a stimulant laxative, but with Senna, what we usually recommend is getting the medical grade one, that the medication. Don't get the supplements, don't get the loose leaf, don't do the tea. And the reason why we suggest that is because you do not know how much active ingredient is in the Senna supplement itself. Because the active ingredient in Senna that helps to improve the contraction of your colon is Senacoid.
Hmm.
So you want to know how much Senacoid you need to produce a better bowel movements, and then you can dose up and down from there. So avoid loose leaf, avoid tea. Uh,
I was looking for my sticker that says it's a picture of a kidney and a liver, and it says if you have these, you don't need a detox.
yes, and or if you're pooping daily, you don't
Yes.
need a
Yes.
detox. Pooping
Yes.
is a good way. And then we talked a lot about how to poop properly and how to improve your gut motility in this video. Somebody asked they were ingredients in gluten-free bread. I have gastroparesis, so those ingredients don't
Mm.
see it. Well, oh, with gluten-free bread, we do have a brand that we love. We love the Shar, Dr. Shar brand. They are gluten-free and low FODMAP certified. They are a little bit on the expensive end, but for anybody who needs to be on a gluten-free diet, we usually recommend, start out with some shortbread and then expand your diet as your guts tolerates other things. Because we do know that people with a more sensitive gut, if people need to be on a gluten-free diet, they usually have a more sensitive gut, and their tolerance to foods can be a little bit more limited. So that's a brand that I absolutely love. I don't know if they have those ingredients in them. It's tricky.
It
And
might be the fiber that's added to
yeah.
the gluten-free bread that for gastroparesis wouldn't be a great fit.
Mm, yeah, that too.
Yeah.
Okay, let me see. But avoid detoxes at all costs because
Hmm.
you don't know what's in them.
Mm-mm.
And because they are usually categorized as a supplement, you don't know what's in them. A lot of the time, some of the research found that they actually have medications in them that make you go
Hmm.
to the bathroom. Then should you be taking those? Like take the actual
Hmm.
medication instead, where we know the dosing, we know the active ingredients, and we know, the side effects of it has been studied. So, be very, very careful of things you can find. Okay, now let me see if I can find questions that people asked on Instagram. Okay. Do we have any other questions on here? Do you want to scroll up and
I
see?
can't see any, for some reason, I can't see any of the comments people made. I don't know why.
Okay, let me see.
Either
Somebody said can't
place.
go to public bathrooms, which I get it. That's me too. Oh, when you say higher dose, how much higher? One dose of Miralax a day does nothing for me. Do you want to
Hmm.
maybe talk a little bit about it? But we don't want to go into too specifics because we do look at our patient's poop when we are adjusting it, but we can give you kind of a range of how high we go with some of our patients.
Yeah, we will go up for very short term, up to 5 doses a night, usually no more than 3 nights. That's a big clean out. So you could certainly start a little bit lower, um, and see how you do and slowly increase. But
Okay.
short term, that much.
Yeah, and I also want to add to that too. Sometimes we hear patients get instructions from their doctor to do a clean out with Miralax. It's a whole bottle of
Oh,
Miralax, right? So for us, recommending 5 doses is not a lot, but please don't do it on your own. Talk to your healthcare provider,
yeah,
get a green light for it first. This is not medical advice. You
yeah,
really need to talk to your healthcare
right.
provider, depending on how complex your case is. It
Hmm.
may or may not be for you, and you may or may
Hmm.
not need it, but please don't go up in dosing laxative all by yourself. Now,
Yeah.
in terms of Senna is the only stimulant laxative that is safe to take long term. We do recommend it when needed. Not everybody needs it. It's
Hmm.
just what we add on as one more over the counter laxative therapy. And okay, I think that is all the questions we have actually. Let me see.
Great.
I think we had a lot of interactions this time, and I love that you guys are joining us. I want to thank you for spending time with us and learning more about IBS constipation. And again, I want to go back to, thank our sponsors, Ardilex, for sponsoring this educational session and for their work in patient advocacy. It's something I don't see often with other companies, and I'm just so shocked the amount of, the commitment they have to connect with patients, to share patient stories with legislators, because at the end of the day, getting more better care and better access for patients helps everybody.
Hmm.
And we're not just looking at like a money figure, right? We're looking at people's quality of life being tremendously impacted. Now, if you are somebody who wants to share your story, let me know. I'm going to connect you with their representatives. And I think they are trying to find somebody in every state so that you can, and give you the tools to talk to your legislators to bring awareness, or they can host events for IBS awareness and invite you as a guest, because you as a constituent, talking to your legislators will be way more effective than them or any of us going in to talk to, a different legislator I'm not a constituent of. And I think them doing some grassroots, advocacy, hopefully it's going to, help us get better access for everyone. So I really do thank our delights for doing all the work they do. Their patient advocates director is a dietitian too, and she is just a fireball of, I don't know how you say this properly, like a power person when it comes to giving patients the power and giving patients a platform to share their stories. Yeah. Anyways, thank you everybody. And for those of you, who want to join our free giveaway, remember to join it now because it ends this weekend, this coming Sunday. So I hope you win, get our free access. Again, we're going to give away to 3 people on Instagram and 3 people on Facebook. That's a lot. I wasn't thinking about it. So a very high chance of winning. Do it on both platforms. So it increases your risk or your rate of winning, the 6-month giveaway. And it does take some time for people to work through the course, which is why we think 6 months is a good amount, because it does take 3 to 4 months to finish the FODMAP challenge. All right. Thank you, everybody. And thank you, Brooke, for joining me today.
Bye.
All right. Take care, everybody. Bye. And let us know if you have any questions in the chat. And if you want to get a free patient toolkit, comment pain to get our symptom tracker and the patient toolkit. All righty. Bye, everybody.
Bye.